Thank you very much, Dr. Cho, and thank you very much, Dr. Coleman and Itzwitsky for inviting me to be here. And being the last speaker, I think I can see where everybody's mental state is at the moment. So I would try to be brief and to the point. So I'm supposed to cover the aspects of what immune-based therapies are going to achieve. None of these therapies are approved, so what we're talking about is what we are looking forward in future to become part of our regular treatment. So there are two types of immunotherapeutic approaches being utilized and investigated. One is passive or adaptive immunotherapy, which is more antibody-based therapies, and in some cases adaptive transfer of CTLs, a very nice abstract you heard earlier in the day. And the second part is more induced or active immunization using vaccine type of approaches. And I would cover both quite briefly. So as long as antibody-based therapy is concerned, there are a number of targets. A lot of targets are on the cell surface of myeloma cells. There are some on the stromal elements. There are some that are cytokines driven or directed, which are cytokines in the milieu. And then some of these approaches are also directed at the bone itself to improve the bone health. Now, the antibodies work through certain mechanism. The most common mechanism is ADCC, antibody-mediated cell cytotoxicity. The second one is that antibody would abrogate the signaling, so it's an active, it is like a drug. And then the third one is complement-mediated cytotoxicity. The most important one is ADCC, which is what most of the antibodies work through that mechanism. Few work through these mechanisms, and some of them are listed here. Now, at the present time, there is not a single antibody approved for myeloma, and we're waiting for our Rituxan to be incorporated into our treatment. And as you will see, we have very many promising leads. There are almost 10 plus antibodies in clinical study. Some of them are listed here. The top two are ones which have advanced with great promise in the early clinical study. The first one has actually gone on to finish the phase 3 study, and we are waiting the results. So you did hear about Elotuzumab quite a bit today. I wouldn't go through everything again. But as it has been one of the most prominent antibodies that we have investigated, it's good to know that this is an antibody targeting CS1, which is present on most or if not all the myeloma cells and patients. In preclinical study, it has shown activity, but very importantly, when it is combined with lenalidomide, in my study, it is one of the most effective combination compared to either of these drugs alone. So keeping this in mind, a number of clinical studies have been carried out. The first one was a monotherapy study, which by itself was not very effective. By itself, Elotuzumab doesn't work very well. When combined with lenalidomide dexamethasone, based on the preclinical results I showed, the overall response rate was 82%. Now, by itself, Lendex in this setting would provide around 55% response rate. So there is clearly some synergism between this combination to give high response rate. Based on this, a phase 2 study, a randomized phase 2 study was done with two different dosages of Elotuzumab, 10 versus 20 milligram per kg. And this study showed that the 10 milligram dose provides 92% response rate compared to what we would expect around 50 to 55%, with a PFS of almost over 2 years. And not only that, but this study also showed that 10 milligram provides better progression-free survival. So this is our standard dose moving forward for this drug. It's also been combined with bortezomib, and the response rate is close to 50%. And a phase 3 study in relapsed disease and in newly diagnosed patient is completed, and we are awaiting the results to see how the combination of these three drugs fares against the standard RD combination. And there are various other trials ongoing for this study. So for our summary of this drug, it is the combination of Lendex with Elotuzumab is extremely effective, providing very high response rate, 92%. It's tolerated very well with minor toxicities, and we have to wait for the results of phase 3 studies, hoping that this would become our Rituxan with standard RVD or other regimen. The second antibody, which is also showing great promise, is Daratumumab. It targets CD38 molecule, which is expressed quite well on all myeloma cells and all myeloma patients. A humanized antibody with potent ADCC and CDC activity, but importantly, it also has the inhibition of signaling pathway activity. It's been shown to have efficacy in preclinical model and also in combination with other drugs. So with this promise, an initial study has been performed, phase 1 study as well as a larger phase 2 study. And as you see here, the response is the typical waterfall curve, that when you go beyond the low dose, the higher dosages show significant decline in myeloma protein. And if you look at aggregate results, when patients get 4 milligram or higher dose, overall response rate is close to 70%, with half of the patients achieving a PR. This is a single agent activity, and in this day and age, when patients get significant prior therapy, to get a single agent activity suggests quite an active molecule. So this agent has a high single agent activity in relapsed refractory patient, a good safety profile, and there are now ongoing studies with lenalidomide, bortezomib, as well as VMP regimen. Of note, there are 2 other CD38 targeting antibody also being developed. So there are 3 antibody against the same target, knowing the promise of this target. So this is another important antibody. A third antibody which works through a little different mechanism, and it's good to know about it because there will be more and more of such molecules becoming available. It's targeting CD138, which is the most classic target for myeloma. It's conjugated with a chemotherapeutic agent, which by itself, when conjugated, is inactive. When the antibody binds to the target, the chemotherapeutic molecule is taken up, metabolized, and becomes activated and kills the cancer cells specifically. So this chimeric antibody drug conjugate has been evaluated in vivo study in animals, 2 different models, and both of them show that in the right concentration, it can kill the tumor cells very effectively. So clinical studies have been conducted, number of them. The 2 studies mentioned here with weekly dose, once every 3-week dose versus weekly dosages, and bottom line that even at these dosages and in early phase, we see responses, partial responses, minor responses, as well as stable disease. And currently, there is an ongoing study of this antibody with lenalidomide and dexamethasone. So these are examples of promising antibodies which are in the clinic. The second type of antibodies which are in the clinic are essentially targeting the bone microenvironment. It includes cytokines such as IL-6, but more importantly, there are antibodies which target the bone itself or the bone disease. Denosumab, which you are very familiar with. PHQ is a new antibody that targets DKK1, and there's a very promising antibody that targets BAF. It's an anti-BAF molecule. It's a B-cell activating factor. So the anti-BAF antibody, Tabalumab, is a human antibody which is being evaluated in a phase 3 study in rheumatoid arthritis, because that's one of the target and important area for important target for rheumatoid arthritis related bone problems. But in preclinical study, this antibody has shown activity in myeloma, as shown by Dr. Raji and colleague from Boston. It shows that animals survive longer and there is improvement in the bone disease. And based on that, a clinical study has been conducted with combination with bortezomib, again based on the preclinical results. And this phase 1 study shows that 46% of the patients achieved PR with a duration of response of 7 months and relatively few treatment-related toxicities. Now, larger phase 2 study is ongoing, looking at 2 different dosages of this interesting combination of the molecule. Another bone-targeting antibody has been DKK1. It's one of the targets that Dr. Barloghi and Dr. Shaughnessy described a few years ago, showing that DKK1 produced by myeloma cells inhibits osteoblasts and contributes to bone disease in myeloma. So this molecule targets DKK1, and you can see that in preclinical model, it increases the bone formation, again by decreasing the inhibitory effect on osteoblast. And also in the preclinical study, it inhibited myeloma cell growth, as you see here, by decreasing the IL-6 production in the murine model. A clinical study has been conducted with this antibody, and we just shown interestingly that the bone improvement is observed in patients. So 9 of the 15 patients at 6 months had improvement in bone by QCT measurements. You can see most of the time points have improvements. The improvement is similar to what we see with currently bone targeting agents. And in 11 of the 13 patients, even the bone markers improved. However, this molecule has not shown the clinical benefit, the anti-myeloma effect. So there's an improvement in bone, but not anti-myeloma activity at the present times in the dose and schedule that was used. So if you look at antibody-related various approaches, there are a number of single-agent monoclonal antibody clinical studies are ongoing, including in bone setting, showing efficacy, and more importantly, encouraging results are being seen in combination. So once we define the role of antibody and the combination that works, hopefully we'll have an R-CHOP-like combination for myeloma. We probably would end up with RRVD or RCRD or some other similar combination. After having looked at passive immunity, now the question comes up, why do we need active immunity? If antibodies are going to work well, why do we need active immunization? And the reason is what you have heard earlier in the day, Dr. Morgan presented, Dr. Barloghi presented, and some of our own data from Boston shows that in myeloma, it's not the 1 or the 2 targets. There are many targets. When we looked at our patient data and number of mutations in myeloma, and these are number of patients, the frequency of mutation is from 28 to 400. And in average, there are 58 mutations in myeloma. So it's a very diverse, heterogeneous process. Not only that, but in a given patient, there is hardly any patient who has only one clone. There are multiple clones. So we are going to target multiple myelomas in a given patient. And not only that, but this changes over time. So from having early disease showing this pattern to a late disease showing very different pattern. So just using one drug, one antibody may not be adequate. We need to have more global approach. And the best way to get a global approach is if we can educate the immune system to target the disease. Whatever is in the disease, whatever is identified by the body would be most effective. So to get an active immunization, we need 3 or 4 things. Number 1, an active functional immune system. We need an relevant targets, effective delivery, and of course, selection of the patient at the right time in the disease process. We know that in myeloma, immune system is suppressed. I won't go into details of what those are, but we know there is a B cell defect, there's a T cell dysfunction, and abnormalities of T regulatory cells and Th17 cells. So we need to try and improve some of this, specifically the T cell dysfunction which is there. So how do we improve T cell function? First thing is to control myeloma well. So having an effective therapy, decreasing the myeloma burden, whatever the cytokines and other factors that myeloma produces, which leads to inhibition of immune function, needs to be improved by controlling the disease. The second is we can target the disease in a stage where the immune system is better. So we can consider targeting MGUS, smoldering myeloma, patients in CR, etc. Number 3, we can use pharmacological agents which can improve the immune system. One of the classic examples of the immunomodulatory drug, lenalidomide, pomalidomide, even thalidomide to an extent, can improve the immune system. So some of the vaccination can be combined with this. And finally, we need to block immune inhibitory interactions. And one of the most prominent and what seems to be the most promising in many cancers, especially in cancers like renal cells and more importantly melanoma, has been inhibiting the targets PD-1, PD-L1, which is PD-1 is quite often is present on the T cells, and PD-L1 is produced by the tumor cells, sometimes the immune cells in the microenvironment, and this interaction leads to immune inhibition. So if we abrogate this, we can get better immune response. This has been demonstrated in melanoma. Similarly, another molecule that is also inhibitory is CTLA-4. works in a similar pathway. And so number of antibodies targeting these molecules are becoming available. 2 of them are commercially now available for treatment of melanoma through this pathway and this perturbation of inhibitory molecule. So similarly in myeloma, all 3 this molecule, anti-PD-1, anti-PD-L1, and anti-CTLA-4 are in clinical investigations. So my colleague in Boston has evaluated an anti-PD-1 antibody in myeloma in a post-autologous transplant period. It is well tolerated, and using this, expansion of tumor-reactive lymphocyte was observed in the post-transplant period, suggesting that this inhibition leads to some immune activation. And this is the beginning of utilizing now this type of antibody molecule to combine with an active vaccination approach. The vaccination approach that we are pursuing with Dr. Avigan is a DC myeloma vaccination. And to give a one-line description, what is being done is that the myeloma cells are fused with dendritic cells and then injected as a vaccine, so that this fusion presents all the myeloma antigen which are present, whether they are changing, whether they are not changing, multiple or single, they are all being presented and leads to immune reaction. Now, initial studies have been done in relapsed refractory patient, which showed the tolerability, no autoimmunity was observed. There is an immune reactions observed for specific antigens, and we have identified some of the antigen using Tregs, and that some disease stabilization was observed, although no clear decline was observed at that stage. The next vaccination was done in post-autologous transplant setting, and you saw these slides shown by Dr. Anderson earlier in the day, where patients vaccinated post-transplant had significant increase in reactive T cells, but more importantly, there was an increase in the CR rate from 29% to 54% after vaccination. Post-transplant period, it's difficult to interpret whether it is just the transplant effect or vaccination, but it appears to be encouraging, and a larger study using the PD-1 inhibition approach with this vaccination is in now works in this patient population. The next approach is using some antigen molecules, so then we can use a cocktail, multiple antigens, so that we can target multiple aspects of the tumor. And in this regard, number of myeloma-associated antigens have been evaluated. The best and the longest studied, but not so successful, has been the idiotype protein. Then there have been cell-based vaccination, but more importantly, MAGE, and my friend and colleague here in chair has done the most work and appears to be the most promising of the target. But then there are other cancer testis antigen as well as other myeloma-related antigen. Showing some of our own results, we have identified some of the antigen using some of the genomic techniques. So using microarray DNA, microarray gene expression profiling, we have identified group of genes, 57 of them, which is expressed in myeloma, not expressed on normal cells, and then identified 9 of them with some functional effect in the cells, developed peptides for 37 peptides against this antigen, and then evaluated their functioning. You could see that some of the peptides can induce specific T cell response. One such target has been XBP1, and when we develop CTL against XBP1, it can control myeloma cells proliferation and cause cytotoxicity quite reliably, specifically in the cells which are HLA-A2 positive, but not in the cells which are not A2 positive. So we know these peptides are specific. And so now a cocktail-related trial is ongoing in smoldering myeloma using XBP1, CD138, and CS1 peptides. So what are the ongoing trials in this disease? There are a number of them, so I'm not going to list each of them individually, but these are trials in smoldering disease, post-autologous transplant, and in relapsed myeloma. And type of vaccination has been whole cell with DC fusion or DCMM lysate. There are peptide-based vaccination with MAGE, WT1, and a few other myeloma-related peptides. And some of these peptides are being combined as a cocktail. So we have to wait and see how these studies provide benefit, cytotoxicity, and more importantly, it's time after working on this for 20, 25 years, and many of my colleagues working for many more years, that we start seeing some good clinical response. But the excitement is that now that we can use molecules like anti-PD-1, anti-PD-L1, or CTLA-4, we can now go for long-term goal that we can treat myeloma with what we heard during the earlier part of the day, get minimal residual disease, improve immune functions, then use the antibodies to overcome the immune inhibitory environment. And once we have obtained the minimal residual disease and improved immune function, we can now use the maintenance immunotherapy, which would be non-toxic, but could have a lasting effect in this disease to eventually get to the cure. That would be an ultimate goal. I think I would stop there. Thank you very much.